Thank you, Kostas. Now, Dr. Maizen, Claudia Maizen from London, has to share her presentation and open her audio and video. Oh, hi, Claudia. How are you?
Yeah.
Nice to have you with us. Can you please share your presentation with us so you can start?
Yes.
Great, thanks.
Work. Excellent. Is it okay for me to start?
Yes.
Can you hear? Thank you. So thank you very much for inviting me to talk about the treatment of DDH according to sonographic diagnosis. Before I start the talk, I want to just briefly introduce myself. So my name is Claudia Maizen. I'm a consultant pediatric orthopedic surgeon at the Royal London Hospital, which is part of Barts Health UK, which is the biggest trust in the UK. Let's see if that works. Mm-hmm. There you go.
Sorry, can you hear me?
Yes.
Can you please talk a little louder and closer to the microphone?
Thank you for letting me know. Does it work any better?
So increase the volume in your microphone.
Yeah, I have. Does it work? Is it any better than before?
I'm afraid you have to talk louder.
Okay, so I'm going to just shout a little bit. Is that okay if I talk in this sort of
yes.
Okay, volume, excellent. So just briefly about the hospital that I'm working in, so Barts Health. Barts is the oldest hospital that's been mentioned in England, first mentioned in 1100. The Royal London site, which you can see here on the right, is the hospital I'm working in. That is the old hospital in here, which was also home to John Merrick, who lived there until his death. He was the Elephant Man, maybe better known to some of you. The Barts site is very close to St. Paul's Cathedral. You can see here the new wing. We also have a treatment center, arthroplasty center in East London. The Royal London site where I'm working here is the largest trauma center in the UK and also a basis for the helicopter emergency services. And we also associated to Queen Mary's University and Barts School of Dentistry and Medicine. So this is the hospital I'm working in. You can see the view from my window is very nice. You're very close to the city. This is my department. This is the pediatric orthopedic department. My consultant colleagues, we are very international. One colleague is from South Africa, one from the Netherlands, myself from Austria originally, Manoj Ramachandran from originally India, then the UK, and Dimitrios, our newest appointment, is actually from Greece. Right, enough from myself and the background. Let's start talking about the treatment of DDH. So first of all, what are the goals of treatment? We want to reverse the pathoanatomical deformity of the joint. In order to do this, we want to make full use of the ossification potential. Growth and ossification potential are age-related, so early treatment is most important. When we treat, we want to also avoid damage, of course. So we want to avoid damaging to the growth zones in the socket as well as in the femoral head, and we don't want to cause any AVN. So why do we want to treat early? We want to make most of the acetabular remodeling. You can see here in this remodeling curve that remodeling rate is highest under the age of 6 weeks. It is still pretty good between 6 and 12 weeks, but after 4 months, the remodeling potential starts to plateau. This can also be seen in the maturation curve of the alpha angle. The white zone is the healthy population. The light gray zone is the first standard deviation. These babies need follow-up. And the dark gray zone are beyond the second standard deviation. These babies need treatment, and ideally treatment immediately. Within this area here, so under the age of 4 months, we should ideally have finished our treatment. So in order to be able to do this, we need to also diagnose early. So an ultrasound scan under the age of 4 to 6 weeks would be necessary to allow for this timely treatment. So when we're talking about DDH, we have to keep in mind that the first D stands for developmental. So a hip that is essentially stable and cannot be detected as DDH at birth can then change, and dysplasia can change into instability and even dislocation. In this graph, we see nicely a normal hip to start with, which is when it is dysplastic, so when the cartilaginous roof starts to deform and flatten, still clinically undetectable. So only with ultrasound can we catch these hips, which can still go on to dislocate. Only once a hip is decentered, we can detect the instability. This is the group of the type D, 3 and type 4 hips. So with our treatment, we want to ideally reverse this process. So we want to change a dislocated hip into a centered hip and stable hip. And then with maturation, this can then go on to become a normal hip. So we have 3 essential steps of treatment. The first step is reduction, then comes retention to maintain the position, and last, the maturation, ossification. I'm going to go through these steps one by one. The first step is reduction. So a dislocated hip is brought back into the fossa acetabula, and this is required for all decentered hips. The D hips, the type 3 hips, and the 4. The reduction can be achieved by any means, really. So that could be with overhead traction on the left, with a public harness, which is the only external device that actually is designed to reduce a hip, and it has to be applied appropriately to be able to cause reduction. This can also be done manually with closed reduction and hip spike application, for example, and if this is all not possible, an open reduction might be required. So the position in reduction is very important. We want to flex to 100 degrees, and we don't want to abduct more than 45 degrees. The position can then be maintained by any external device. Important is no abduction without flexion, because if we abduct without flexing the hip, the head is pressed against the hyaline cartilage. And as it's pressed against the cartilage, the sinusoids within the femoral head can be compressed, and this can cause AVN. It is important to say that avascular necrosis is always iatrogenic. The second step after reduction is the retention. So we want to maintain the centered position of the hip. Retention is required in all type 2C unstable hips and in all hips that have successfully been reduced to type Ds, 3s and 4s after reduction. The position of retention is in the human position and within the safe zone. We can see what happens if the hip is abducted without flexion on the left side here. The femoral head is pressed upwards against the cartilage of the acetabulum. This causes a growth disturbance of the socket of the acetabulum, as well as compression of the femoral head, and can potentially cause AVN. In the right picture, you can see abduction in combination with flexion to 100 degrees. The hip is now pressed downwards, not against the acetabulum, and the pressure is not increased. The old position the hip spikers used to be applied on is the Lawrence position. In this picture, you can see the hips are abducted quite markedly, almost 90 degrees, and there is no increased flexion. Flexion is not increased beyond 90 degrees. This is a clear no, so this is what we want to avoid, because this is damaging the hip joints. This is what happens inside the plaster like this. The hip is pressed upwards, as showed before, and compression forces on both ends, the acetabulum as well as the femoral head, can cause damage. Now, this hip spiker is not the worst that I have seen. I've seen many hip spikers that, that did not end above the knee, that came down to the ankle joint in a forced position of abduction, not enough flexion, and even internal rotation. You can see that the peak joint pressures are worse for forced internal rotation, followed by abduction and forced external rotation. So any extreme position should be avoided. The position we want to aim for is the human position, flexion of 100, and abduction not beyond 45 degrees. In this position, the hip is safe, it is reduced, and pressures inside the joint are reduced as much as possible. An example of treatment of successful reduction and retention here. On the right side, we have a type 4 hip. On the left, a type 3 hip at the age of 10 weeks. Both hips are reduced, reduction is maintained, and the hip is then a stable hip that only has to mature and ossification has to occur. This brings us to step number 3, maturation ossification. This is necessary for all dysplastic hips that are stable. So type 2A-, 2B, and 2C stable. And of course, all the hips that have already been treated, like the unstable and the dislocated hips, after successful reduction and retention. Maturation ossification has to carry on until the hips are normal and have achieved to be a type 1 on ultrasound. We can see on the picture, the pressure of the femoral head is downwards and inwards, which reduces the pressure on the growth area in the acetabulum, and the acetabulum can mature and ossify. So another before and after picture, a dislocated hip type 4 after successful treatment turns into an entirely normal type 1 hip. So when we talk about intervention, we should also talk about prevention. As we said, DDH is a disease that develops not necessarily in utero, but also after birth. So what we want to avoid is any position of the hip where the hip is extended, so straight and even adducted. In extension and adduction, the hips can dislocate. This is also applicable nowadays because swaddling is in some areas still very popular. And this is something we have to educate midwives and parents about to avoid any restriction of movement in the hips and the legs. Correct position for those that do have to swaddle or do wish to swaddle is to have a specific device that allows full movement for hips and legs while the arms are tucked in. To show how important this is and what impact it has from a public health point of view, we know that Chinese Bantu Nigerians carry their children on their back, and they have a very low rate of hip dysplasia and rare hip arthritis in adults. The Navajo Indians used to carry their children in a cradle board and had an incidence of hip dislocations of 2.7%, which is very high. And after this diapers have been introduced and the cradle board was not used in that extent anymore, the incidence has reduced to 0.7%. In Japan, the incidence of hip dislocations has reduced from 3% to 0.2% after a national program was introduced to eliminate swaddling. This reduction of hip dislocations is better than any sort of screening or selective sort of screening program. Australia has also shown to increase DDH threefold after the popularity of baby wrapping or swaddling. So prevention is very important as well. So when we talk about treatment, and I speak from my personal experience and point of view, I would also stress again that early diagnosis is most important. With early diagnosis allows us to treat early. We have a responsibility towards the patient and the parents I want to be able to deliver the best available treatment strategy with the best possible outcome. We want to avoid complications, of course, early and late complications of the disease, but also of treatment. And we want to treat as minimally invasive as possible in order to reduce the impact on the children and on their families. When I speak about minimally invasive treatment, that means early diagnosis and treatment. We know that pelvic harness success rate, for example, is highest below the age of 6 weeks. It's quoted of up to 93%. Whereas if harness treatment is commenced after the age of 4 months, the success rate goes down to 37%. So if we start after 3-4 months, then this is very often what we are facing. Late presentations, dislocated hips, even in walking age and beyond. These children unfortunately require surgical interventions, open reductions, at least, if not hip reconstructions, which have a high risk potential. What we want to avoid as pediatric orthopedic surgeons is what happens after we discharge these children, normally after the age of 16. Late dislocations and arthritis, but also AVN caused by treatment, both leading to requirement of hip arthroplasty. When we talk about treatment, we also have to talk about over-treatment, because this is an argument that is very often used by people against universal screening. What is with over-treatment and complications of treatment? So if we're looking at the literature and what has been published after implementation of universal ultrasound screening in Austria and Germany, for example, we can see that over-treatment should not be something we should worry about. Van Gries has published the numbers of the health statistics in Germany after implementation of universal screening, and has shown that the rate of first operations by the age of 5 years has reduced to 0.26 per thousand. That has reduced from 1.6. And if we consider this number, we have to also consider that this includes all first operations, including closed reductions, which are generally and standardly done for all dislocated hips in Germany and Austria. If we're looking at the essentially late presentation rates of open surgery within 5 years of life, this has come down to 0.09, so practically zero. Grill et al. Has published the statistics for the Austrian Ministry of Health after the implementation of ultrasound screening in Austria, and the reduction of open surgery rate to 0.14. We can say that the number or the rate of hospital admissions has reduced by 46% after implementation of universal ultrasound screening. Newer numbers confirm that. Biedermann et al. From Innsbruck has published that primary open surgery within 5 years of life have reduced to 0.04%. Now, what I wanted to highlight here is that the treatment rate is quoted to be under 1%, which is lower than any other published treatment rate. If we compare this, for example, with the treatment rate that is quoted in Scandinavia with selective screening, there are 2 RCTs that have been published with a important to highlight here is that a different ultrasound method is used in Scandinavia, the femoral head coverage. And using this method in the universal screening group, the treatment rate was 3.4%, which is threefold of what is quoted with the graph method in Austria and Germany. At the same time, the late presentation rate, which is essentially quoted with 0.04 and 0.09, is 0.3. So also markedly higher. If we take the arm of this randomized control trial that used selective ultrasound with the femoral head coverage, we had a treatment rate of 2%, so still higher than the treatment rate with universal screening with the graph method. Of course, the late presentation rate has also gone up in this group. And if we now take the last group, the clinical screening group alone, treatment rate is still higher than with universal screening in Austria. Treatment rate with clinical screening in Scandinavia was 1.8%. and late presentation rate very high, 1.3%. Just to throw in some numbers from the UK, our late presentation rate is around 1.6%, which is high. And because the selective screening that is practiced in the UK is not organized very well, the late presentation rate has actually not really changed since selective screening was introduced in comparison to clinical screening alone. So important, and I want to stress this also, is not only early diagnosis is important, also the correct diagnosis is important in order to deliver safe treatment. So the prerequisite for the correct diagnosis as well as early diagnosis is that the ultrasound technique used should be standardized and reproducible. It has to describe the pathology, and it should classify dysplasia as well as dislocation and instability. Important is that it has to take age into account to avoid overdiagnosis and overtreatment. And it should be correlated with a clear treatment strategy. So to just summarize our treatment strategy overall, so we have reduction, retention, maturation. We want to reduce all the D-center tips, the Ds, 3s, and 4s. We can achieve reduction either manually or with surgery. We might be able to use overhead traction or public harness treatment. The second group, the unstable hips, require retention, and of course all the D-center tips that have been reduced before. And this should be in either a hip spiker or can also be in a public harness in a human position. Maturation for the dysplastic hips that are stable, as well as all the unstable hips that have been retained, and the D-center tips that underwent reduction and retention. So again, this should be in the human position, can be done with any abduction orthosis, and the length of treatment here depends on maturation. So the older the child, the longer this treatment will need to turn the pathological hip into a normal hip. So just to show that with some other pictures again, reduce, retain, mature. And after this process, hopefully, we will have an entirely normal type 1 hip, and we will have children that can run and jump and play without any pain or restrictions. Thank you very much.
Thank you very much, Claudia, for this excellent presentation. We will move now to our colleague from the pediatric clinic, Dr. Palabu.